Anybody for the first question?
I want to congratulate you both. Very beautiful debate. Thank you very much. Great arguments. Gabriel, I have a question for you. Do you think the sex should be supervised in adolescence?
That sex should be supervised?
It's a very dangerous activity. It can lead to pregnancy, it can lead to hepatitis, HIV, STIs. Should we supervise sex?
Absolutely not, obviously. However...
That was my question. Because the test is related to them having unsupervised sex.
You could make that argument. I'll just say that, yeah, I mean, the other thing is, would you want to have unsupervised, for example, pap smears? Do you have an unsupervised vaccination? So I'm not trying to equate self-testing to all other services, but I think completely pulling it out as a standalone has some risks we need to acknowledge. I'll stay away from that question, though, for a variety of reasons.
Okay, we have Pablo down here.
My question is related to the question itself. It says should be implemented. So Cheryl, you wanted to offer it or implement it, which I think is a little bit different.
Well, I think for implementation, when we talk about it, there's differentiated care, there's differentiated testing approaches, and so I think implementation is nuanced. So that will be offering it, and I think what I interpreted the debate question to be, should it be implemented for all without restriction? And I think that's really where I would think about anybody who's implementing testing for pediatrics. Do we do community-based testing or universal testing for all populations in all settings? We don't. As providers, we're always making those decisions. And so I would say for self-testing, it's a programmatic approach. And as those slides I was going through to say, based on who you're trying to reach, which adolescents, you're going to implement it differently, but it should be accessible and able to be implemented for all.
Okay, wordsmithing. Let's go to number one.
Cheryl, I'm just wondering if you could describe any package of support that you would add onto this self-testing, and depending on what that might be, is it actually that different to community-based testing?
Within the self-testing package, there's pictorial instructions for use. That's available for all. And then there's hotlines, there's community-based distribution and demonstrations. So it's one of these things where we've actually seen a lot of success to say, did we not distribute condoms because people needed demonstrations? Did we limit ourselves? We didn't. We found solutions to support people who needed the prevention or the testing technologies that we knew would help prevent them and protect them from HIV. So similarly, demonstrations, hotlines, follow-up by community-based distributors, there's endless possibilities. And there's also some really innovative mobile and smartphone applications, as well as I'm trying to think the technology. I'm an old person. I need an adolescent to help me. So I think that to answer your question, there's lots of support tools, and we're really looking at different ways to optimize self-testing for adolescents and young people. And I think getting the feedback from the implementation studies will be really helpful to decide which ones work for which populations best.
Gabriel, do you want to come back on any of those two?
Yeah, I mean, one comment is just that I'd be wary of a simple fix. So the idea of just, HIV self-testing is solving these problems, just get it out there. It does bring up the potential of kind of taking the focus off, I think, some of the push you need for, in certain contexts, universal testing or testing that has more support offered, not less. And sometimes the allure is something of a new technology. Also, I think you can bring up condoms as both a pro and a con in terms of how well they work done.
Okay, I think that's Alice over there.
Yeah, hi. So I have another question. If you could clarify some of the acceptability data. I've read a number of those articles. And just to describe a bit the way that the self-testing was delivered that made it acceptable to those young people. I think in one in particular in Cape Town, it's done in a youth-friendly van that young people know that was already doing testing. So I think it's just important to kind of if we could have a bit more of information and clarify that acceptability data.
Definitely. I think that I presented kind of a high-level analysis to say across a number of different implementation models, we've seen it be acceptable. So for young MSM, we've seen that self-testing is really acceptable through an e-testing platform in Brazil. So there's some data there. The Cape Town study that you referenced, a lot of the studies that have been done in Southern and Eastern Africa have really used community-based models because those are really strong and very acceptable to adolescents. And so I think you can leverage those platforms. And I think what I would say is there's going to be lots of different models depending on the context. And if we're talking about all adolescents, we have to kind of take that differentiated testing approach to the adolescents to really learn from the lessons of community-based testing. And just to kind of come back to Gabriel a bit on his point, we're trying to get self-testing to people who are never going to come to those community-based sites, never going to come to those facility-based sites. So it's really about extending the ultimate task sharing, if you will. Say you're trying to get out there even further because you know you've got that gap. The community-based testing, the facility-based testing is not reaching the adolescents. And so I think that's something where we really have to weigh the risks and benefits and say, how are we going to close that gap? And we have to think about self-testing as an added value to do that.
I guess one could argue it could reach all those adolescents. Just a question of will it? Is there a will, or is it going to be just kind of pushing it onto a new technology, focusing on self-testing and saying, you could argue, are those people who are not coming to any community-based testing venues, not coming to centers, are they really going to go to a health center or a pharmacy or wherever and pick up their self-test and do it appropriately? Some may, but I just don't know that it'll be the solution for all adolescents.
Lynn.
If they're not getting tested because you're not reaching them, my guess is that they'll have an HIV test and not get linked to care either. To go back to what you said before, it sounded like you weren't saying implement for all adolescents. You were saying implement plus something for adolescents. So it's not, you said, oh, there's a variety of support services and we need to do this and we need to do that. And that to me is not just implementing testing. It's testing plus something. So to me, that's not necessarily implementing testing without something. It's more like implementing testing plus something, which is what I think Gabriel was proposing.
Back to our definitions.
So I think that is almost quite a challenge because self-testing is not a definitive diagnosis. You can't provide a positive diagnosis with a self-test. So it will always be plus. And even the studies Gabriel was citing, the SEARCH project has incentives, it has lots of support, linkage to point of care CD4. The list goes on about what's in the package of community-based testing. So if you want to split hairs, I think we could say that community-based testing is a lot more than just testing. And self-testing, it's not going to replace testing. It's a demand creation tool. So when we talk about implementing it, it is always going to be plus additional services. And I think that's how all testing should be implemented. Whenever we talk about it, it should be HIV testing services. I think if you look at the WHO guidelines, that's what it's called, and that includes linkage to care services, includes counseling, and includes a lot of support, linkage to prevention, linkage to treatment. And I think we really have to move in that direction overall, and it should always be that. So I don't think it's apples to oranges. I do think it is as close as we can come to apples, noting that the self-test is not a definitive diagnosis. So for those positives, they do need those services.
We're going to come closer together as time goes by. But yeah, I would argue do more. Yes, I mean you should do more. I think that is the risk potentially with HIV self-tests that are unsupervised. Is some of the more you could provide, some of the outreach you could provide. There's a potential for either policymakers or communities to shift the responsibility onto an adolescent to say, go get your self-test, you could do it yourself, or not to think about all these ancillary services and perhaps to take the pressure off the need for these services. So that's a potential a risk of that. And I think, yes, you do need a lot to get people, particularly young people, to come test for HIV. In a very simplistic example, if you think you put up a sign and you ask people to stand here to test for syphilis versus come here, stand here to line up for medical care, they're going to go to the medical care line, not the syphilis line. So, I think you can all kind of arrive at that in your head. And the same thing with HIV self-testing. You may not want to be, think about young people buying condoms in a pharmacy, available, not easy to go up and walk to that counter. I think self-testing is that same issue. So I would argue if you're saying yes, it takes more to do these community health-based approaches, I agree that that's what we should be focusing on, giving more, not less.
Okay, before this debate, they're both totally agreeing. Let's have one more question, and then we're going to give you a minute each to sum up.
I just want, if Gabriel can clarify, if in the search, the data you presented quickly for Uganda, and if adolescents reached the same 80%, or if they were significantly lower on the testing, or if you didn't happen.
Yeah, great question. So both in young men and young women, we reached the 90% across all categories with the exception of 10 and 11-year-old Kenyans. And the reason for that was there was parental permission. Despite that, in our graphic, you can see we're still close to the 90. I think we were about 75 to 80%. But that parental permission problem was there. That's, I think, regardless of testing modality. But otherwise, 90% across the board. Yeah.
Okay, there was one question. Is it a very quick comment?
Quick, it's kind of just to play devil's advocate a bit, but the WHO definition of adolescence is 10 to 19 years old. So are we saying we're going to implement this for all adolescents from 10 years of age And I think the frame of this has been all the adolescents, but the definition of adolescence is 10 to 19, and perinatally HIV-infected adolescents are going to be included in that. That is going to disclose parental HIV infection status.
Okay, do you want to try that? Do you believe in the WHO definitions of adolescence?
Defer to my WHO colleague.
You have me there. So I think that that's going to depend on the setting that you're in. And I think that when we look at what makes sense for implementing for all adolescents, we see across countries, even though WHO defines as 10 to 19, a lot of countries do not. And so I think we do need to kind of think through, there is a little bit of gray area there to say that, what is that magic number within your group of adolescents where you would want to start self-testing? So I definitely agree with that.
Just one quick comment on unsupervised rapid antibody testing is that I think, as many of you know, or all of you know, if someone is on antiretroviral therapy for a long period of time, these self-tests can be false negative, speaking of reassurance, or perhaps misleading someone on the results of a test. That could be a problem in perinatally infected kids.
Okay, now we come to sum up. First of all, Cheryl, you've got 1 minute. You want some slides? You can have them.
So, the evidence is clear adolescents need to access HIV testing, and self-testing create demand and enhance access among other benefits. Self-testing is highly acceptable, safe, and effective. There are no adverse outcomes that we've seen in randomized controlled trials. The community messages and support are needed, so I think as we've just discussed in our debate, that's a critical piece. Health workers have been self-testing for a long time, and I think we do have a habit of restricting access to adolescents and telling them what they can and can't do, and it is paternalistic. We have to think about that we offer all other HIV testing approaches to adults, and adolescents are actually the ones who need more options, so why are we making this discussion about offering them less? So current approaches alone are not enough, and implementing self-testing will be the only way to kind of increase testing for adolescents and achieve the first 90 at the correct time, the 2020 targets, as well as the fewest resources. So I just want to spur us to say, within some nuance, that self-testing access for adolescents, we have to enable that. There will be a need to focus testing for some. Optimizing implementation is essential by engaging adolescents in the design, implementation, and monitoring of self-testing. And as with all testing, no coercion or mandatory testing, policies to protect against stigma, discrimination, and criminalization will be essential. It's time to end paternalism. Vote yes. Adolescents are counting on you. I will.
Well done. 1 minute, 35 seconds. And Gabriel, I'm afraid you only got a minute because you used an extra 30 seconds.
I'll try to keep it to 30 seconds. Yeah, all right. Okay, so HIV self-testing is certainly an answer to some testing challenges, but not all. So don't be lured into a new technology as the cure-all for the problems that we face. Just to give one example is access. A need for removal for testing barriers, such as parental permission, really remains regardless of testing modality. So don't lose focus on that. Anonymity, decreased stigma, just to bring you to the condom example, perhaps not. I mean, you have to go pick up self-tests from a healthcare setting or community outlet. This may not overcome stigma in the way that we anticipate it will. Lastly, remember that lower rates of user error from high-quality RCTs. I won't dwell on that. And let me just finally quote respected authority on HIV self-testing. It may not be an appropriate or safe approach for all populations. It's really important that information on where and how to access other HTS approaches, including community-based options, continue to be provided. Wait for it. Cheryl Johnson, AJS. So key takeaway, vote no on the proposal.
Okay. Green is for Cheryl, and red is for Gabriel. Up they go. Wow, that's pretty close. We've got another helper here, so I've lost count. It was very close. So actually, have you finished counting? Because I would like you to all put your things down. And then just those who've changed their minds and gone from green to red, put up your red cards. 1, 2. Okay. How many of you have gone from red, that's no, to green? Okay, I should have done it that way the first time. But thank you very much. We're a bit late for tea, but thank you very much for our wonderful